to everybody. I'm happy to be here again with you. I hope you see my slide and my presentation.
Yes, we can see.
Okay, perfect. As you just introduced me so nicely, I am here today to talk to you about my second topic, immediate and early implant placement as one of the major factors for predictable aesthetic results. And not as last time, as I tried to share some basics with you, I would be happy to discuss with you a few cases out of our office, which we are dealing with on a daily basis. And of course, it's a lot about front tooth restorations, immediate implants, and so on. And I think there's a lot of things we have to talk about, and we can take a critical view and we can discuss about. On the left side, you see find the right way. It's there are many possibilities to get to a very nice result. And of course, I'm aware of the different concepts that are published and that are presented by very good doctors, and which all makes a lot of sense. And we need to know all about those concepts, and then we have to decide which one is the best one for us. And of course, which one is fitting best to the situation we're dealing with right now, because every patient is different. And of course, we cannot always have the same procedure for every case. And so it's a lot of experience we have to make, and the therapy concepts have to fit to the ability we are having and we are comfortable with, and then we will be hopefully successful. And anytime we have to place implants in the aesthetic smile zone and this demanding areas, we have to be aware about all the problems we can face and about the complications we can have. And it's never easy to be successful in this area or to get out the maximum result. And this we have to communicate also with the patient, and we have to make the right decision all the time during the treatment, and we have to be able to change the concepts during the treatment when things are happening which we did not expect. So first of all, we need to understand what is this all about. And when we see here, it's a nicely restored, or at least it seems to be nicely restored front tooth area with implants, with soft tissue, with papillae, and so on. And it's all about the bone support of the reconstruction and the soft tissue, and the support of the soft tissue regarding the prosthetic devices and the approaches we have. And then if everything goes together hand in hand, and the team is working properly, also with the dental technician and the motivation of the patient, then we will be successful. And our biggest demand is to be safe, to be secure in our treatment, and to be on a long distance successfully. So we want not only having success in the first period of the treatment, we also want to have a long-term successful result. And this is what it's all about. Our patients want to be happy with the treatment after 10, 20 years, and maybe longer, or 30 years. And this is what they deserve. And first of all, we have to understand what is happening when we are losing a tooth. When we have a traumata or infection or periodontal problem. So in the meantime, we need to understand what's the reason why we are having to deal with implants, and then what the facts and the consequences are. And of course, everybody knows when we're losing a tooth, we will lose bone. And the big group from Linde and Arujo from the Swedish great dentists there, we know that we will lose bone, we will lose bundle bone and volume. And we also know maybe that we cannot avoid that, and maybe we can compensate it. And maybe we are better than the results we know from the Swedish group, because the hardware became better, or the techniques may be better, or the compensation is machine better, is maybe better. And I think we don't have to accept all the resorption. I think we can work with it, and we can get some compromises which make it look better than maybe we were afraid of before. But anyway, 90% of the bony structures there are thinner than 1 millimeter. That means whatever we're doing there is very critical, and it's very, very sensitive to resorption. And of course, an augmentation procedure is absolutely necessary. And Hein Ba and colleagues published very nicely in 2010 that we need that augmentation procedures, hard and soft tissue, and maybe both together, and maybe in some cases first hard tissue, later soft tissue, or whatsoever. And we absolutely know we have to deal with the loss of volume. That's what it's all about. So let's take a look into the first patient case, just to understand the resorption patterns in our office. At least it's a very young patient due to a bicycle accident. He lost 3 of his front teeth, and of course from the first day on we have to deal with losing volume, losing bone, losing properties to place implants very nicely, or to restore the case. So how did it came out? At least the aesthetic guidelines we have to follow are a lot of horizontal lines we have to restore, and especially the incisional outline has to stay the same. And it means that we have to be very good at the red part to get back all the volume there. And if we are getting a very nice result, the soft tissue sulculary outline will follow the lifeline regarding to the incisional outline, and the lip line, of course. And so the planning also has to be very, very concentrated on the white aesthetics, and then the red aesthetics have to follow, which means to us that we have to be very good in restoring that part if we can. If not, we have to think about red, pink aesthetics maybe, or whatsoever. So our approach is always to start in a case where teeth are missing, to have a backwards planning with the result we want to achieve later on regarding the white aesthetics. And then we do everything to get the pink aesthetics going again. So here, teeth are gone. The patient came to our office 5-7 days after the accident. And then we're talking about implants. So we cannot place immediate implants because teeth are gone anyway. So now we have here 3 missing teeth, and we can choose placing 1 implant, maybe not a good choice, but placing 2 implants or 3 implants. And as I told you in my first lecture, for us, it's always easier and better to place pontics in between the implants. So 2 would be the perfect number here, not 3. It makes it more easy and more predictable to play with the aesthetics using a pontic in there. And then still, where should we place them, the 2 implants? In this case, I would, if I could choose, I would rather go to the best possible areas where it's mostly easy to place and to augment the implants. But of course, we need an implant in position 2-1, as Europeans call it. You would say different. I think you would say tooth number 9, if I'm counting correctly. But anyway, national wise, so 2-1, we need the implant there, and then I would place one in 1-1, tooth number 8, and would use the pontic for the lateral. It's very difficult to be close enough to the canine. So aesthetic wise, I think it's better to use a bigger space for the restoration for the canines, for the front tooth 1-1 and 2-1, and not using the lateral. But anyway, if 1-1 would be in a bad shape, I would happily switch to position 1, 2 or number 7 and use a pontic in the middle of the 2 implants. But now, as it seems to be more difficult to place implant number 9 or 2, 1, I would rather use both of those front tooth implants and use a lateral as a pontic. But anyway, this is the planning, but the planning is a major fact for having a predictable result. So this is our surgical approach for now a delayed implant placement. And also, I don't show you so many delayed implant cases later on. I have to say delayed implant placement after 8 to 12 weeks after tooth extraction or tooth loss is the most safe approach we can have, because the biggest advantage is I can place implants, I can do bone regeneration, and later on for the second stage, I can correct soft tissue. I can add material, or I can add, when we're talking about datum dental, I can add volume max material to get a better volume there, which is more difficult when I place an immediate implant. There everything has to be okay. And it's much more difficult to correct situations later on. So this is, to me, the biggest advantage in using a delayed implant placement. So the incision line is more placed to the palatal area. The best blood support we have in the middle of the crest. So normally I like to have my incisions mid-crestal, but here in the frontis area, because I don't want to deal with scar tissue horizontally on my papillae or scarea through my papillae, I prefer to put the incision more to the palatal aspect of the crest, because this will protect me from having, when I have resorptions, to have my scar tissue through the papillae. So this approach, we will always do a full flap to the keratinized tissue going over to the mucosa, and then we'll go over to her split flap design in order to get volume in there without tension when I will close the whole thing. The implants are placed due to a backwards planning drilling guide. To me, it's very important to have the circular outline in there, because I want to place them, if you remember correctly from my last lecture, 3 millimeters below the deepest point of the circular outline I want to achieve later on. So here you see two 3.8 millimeter implants positioned due to the drilling guide. Seems to be correct. And then let's go back. And then we close everything without tension to preserve a lot of volume. This is what I would love to have, and the healing is looking great. We still have some volume in January 2014. That's when it happened. And then we will have to deal with the resorption. So we are always running behind the volume loss, and we have to compensate that. And later on, we have to deal with it prosthetic-wise, or maybe with a second stage surgery. Here you see on the left side, with a little imagination, how it could look. And on the right side, you see already that we are losing volume. Yeah, this is what we have to expect. Maybe also due to pressure from the removal device he's wearing, but even if we don't have that, we will have to deal with resorption. So this is what it is. And now we have to compensate it due to the second stage surgery and due to the prosthetics. And we have to be very carefully build up some pressure to push papillae vertically to stabilize it. And it's amazing how nicely we can get better results due to the correct prosthetic devices. So prosthetics goes hand in hand with surgical approaches, and will make your cases really better later on, or can compensate the limitations we have surgical wise. So baseline, even from the palatal area, we see we lose volume vertically very bad, because it's very difficult to compensate horizontally. Also, I think here we are a little bit more predictable. So later on, this case I did with the department from Professor Edelhoff, very famous prosthetic professor at the University of Munich. And I knew when he's sending me a case, we have to be very, very good and very prepared. And he was sending over to me due to one of his co-workers this picture, and showed me, which I knew ahead, that we will need more volume in front of those implants. And the green line is showing me where I need to go. So I'm not so afraid for the horizontal defects, because I can do that pretty predictable with a roll flap from Abrams, 1997, published. And this is very predictable. We could also use a free changeable grafts or some other techniques. We will go to that points later on in the lecture. But anyway, a roll flap is very predictable to solve horizontal volume deficit. This is how we turned out to be pretty more successful here in that case. So yes, limitations, yes, resorption, and yes, delayed implant placement after 10 to 12 weeks, maybe here in that case. Soft tissue is regenerated, and we can do everything with it. We can close, we can augment safely, and later on we can compensate volume problems with the second stage surgery. I think the most predictable approach we can have in cases like this, and I hope I could demonstrate what resorption processes we have to deal with in all of those cases. Of course, losing more teeth is more difficult than when we're talking only about 1 or 2 teeth, maybe. Success, planning, biology, function, and aesthetics. This has to go hand in hand, and as we see at a group of Dutch dentists and Professor Boozer, who are looking into those failures, problems we're dealing with in implantology, the planning is a major key factor. That means before we start the treatment, when the planning was not correct, we already created the problem. So the correct and precise planning is very, very important, of course. And today, a drilling guide in demanding cases or 3D planning means good preparation, perfect planning, and leads us to more predictable outcomes. And if you take a look at the drilling guide on top of the 3D picture or slide, this is very important to me. Not in that case because I want to place for every tooth implant. I told you before, I love to place pontics in between the implants, but I need the sulcary outline. This is important to me, and you see that demonstrated with the white acrylic material. This is my guideline for the depth of the implant placement, and I want to be 3 millimeters below. So this is very important to me. I just wanted to underline that before I go on with my lecture. Here's the next case. Stabilization, preserving, to me, better than reconstruct material. So if I can, I would love to use a approach that helps me to provide resorption, to limit it, to support tissue and hard tissue. And this is what I would like to try to demonstrate you in my lecture, that we try to deal with every factors to go into that field, to keep volume, to keep natural material in place. And of course, we need the surgical and the prosthetic approach there. So here you see some, at least acceptable looking papillae. The soft tissue looks okay in that case, and still it's an implant. It's only one implant, it's one tooth missing. And as we know, the attachment is generated by the neighboring teeth. So if we have attachment loss there, again, I told you that last lecture, if we have attachment loss at the neighboring teeth, this is major critical problem cases. Here it seemed to be pretty okay. Still, we will lose volume, especially to the horizontal aspect, and we have to stabilize it with a prosthetic device being very slim down there, and then going into a root shape on the level of the sulcary outline. And then we can get to acceptable, nice results. And this is hopefully what you also think, what we see here. And on the lower line, you see some pictures showing you what we like to do that. We like to place implants immediately. We like to place them delayed. We like to use tooth discs with attachment on it still, vital ones, to stabilize the tissue in place. We will go there later on. We like to use maybe immediate restorations or filling gap concepts, and all those cases can be fitting to your next case, and we need to be able to switch and to adapt and to be flexible in our treatment plan. And this is basically what I would really like to show you today. Some cases, some flexibility to change maybe from the one situation to the other end. When we work there, we have to be able to do all that kind of concepts and to choose the right one or the fitting one, and then we have to stick to it. And we have to be aware that we can be successful with many approaches. We just have to be aware of what we are knowing, what we are able to do, what our experience is, and what we're prepared for. And of course, I think it's nice to use the emotional profile we get by nature. So when I take out a tooth, I will deliver my dental technician, or I will scan the root or the surface of the root to use it as a example for my emergence profile later on. And the emergence profile is what counts for the aesthetics. Our patients will take a look at the outline there, and then they will judge our result, and they will decide if they're happy with the treatment or not. And that's what we all want. We want happy patients. We want healthy patients, and we want happy patients. And our treatment should be painless, fast, and should be correct and nicely done, and with love to the detail. So when I was in the Netherlands from 2000 to 2010, with very great and nice colleagues there, we took a deeper look into the different approaches, and it's published in 2010 with a 5 years result. Now it's even 15 years. And we had a group of 91 implants from immediate placed implants. We have 50 implants delayed placed, and we had 18 implants placed and restored directly. Due to the situation which was fitting or our indication, we decided to do one or the other technique, and we compared it with a delayed placement and delayed loading of 615 front tooth cases, so quite a lot. And just out of the office, and these were the results. So here I just present to you the survival rate of the implants, and what we see is that we're basically pretty much the same no matter what we're doing. That means a delayed implant works just as nice as a direct placed one, or maybe a delayed placed one. We're not looking into aesthetics. Maybe this is also interesting here, but just the survival rate is good. It's perfect. It's 97, 96%, or 98 or whatever, or maybe 100. So the best group is, by the way, the direct loading group, but it's only 18 cases, and those cases were selected very special and carefully. So it's hard to compare them to the others. But anyway, if we do the right, or if we choose the right indication for one of those techniques, we will be successful with a very high percentage in the front tooth area. And I think this is very important. And then we have to keep in mind the aesthetic risk there to see if we could be more successful with one or the other technique. If we are looking into the publication of that group of experienced doctors, then we see that they don't advise us in a normal office, which is not placing implants on a daily basis, that we should avoid maybe immediate implant placement because it's a risk, and it should be not recommended for the daily practice. I have to tell you, I'm not 100% of same opinion there, because there are, to me, there are no easier ways to get to a nice predictable aesthetic outcome and results than using immediate implant. But of course, I have maybe some experience and some years of doing that, and I'm aware of all the problems I can have with what technique whatsoever. But if you ask me, the best possible, easiest, predictable outcome to have a great result, I would say immediate implant if the indication is fitting is, to me, choice number one. But that has also to do maybe that I like to do that immediate implants. And on the left side here, you see my first publication on immediate implants years ago, more than 15 years ago. And it was a tooth with a chronic apical infection, which restored everything, no problem to place implants here without acute infection. We know that from Professor Schulte for a long time with immediate tubular implants, and from the group of Zurich, which showed that chronic infections are no contraindication for placing immediate implants. And this case gave me a lot of motivation that we should look deeper in that field of immediate implants. It's never that we should do that all the time. It tells me that in cases where it's fitting, we should talk about that, or maybe we should do that, or probably I would do that at least. If you look again on the bony structures, then we see many of those bony bundled bone, labia, bone shield, bone structures are less than 1 millimeter. Most of them, by the way. So whatever we do there, it's very thin, it's very fragile, and we will get problems there. We know that, and our treatment means that we have to deal with that and we have to compensate it. So immediate implants, here publication now 12 years old, very safe, very easy. Okay, it worked also, but maybe very well elected. I platform switched front tooth situation with healthy tissue, which makes me happy. With brilliant dental technician from Münster, Andreas Nolte. So the wide aesthetics, all the credits go to him, of course. But anyway, a nice team approach, motivated patient, and a very nice result. And I placed it immediately. I took out the tooth. I didn't raise a flap. Raising no flap means dealing with less resorption. Also, we have to keep that in mind. And then using that drilling protocol, you see here on the right lower side, the publication, or one of the publications in 2008, we will perforate the palatal bone structures with a round burr, and then we place the implants there stable, more apically than the root is, to get a nice outcome. And here, that's what we have to be, or where we have to be with a drilling protocol. Palatally orientated and away from the labial aspect, at least 2 millimeters, not to deal with recessions around our prosthetic devices later on. And then that's where we have to place our implant. And then we have a gap to the buccal bone plate, which hopefully still is there. And I will also show you some techniques how to compensate it, to augment it during an implant placement or immediate implant placement. But that's maybe even more special. But anyway, we have to be away from that area, and we have to stabilize the implant during placing it, because it will have the tendency to drift to the labial aspect. Yeah, so you have to stabilize it during placing it and place it back there in the palatal bone wall. And then we can deal with that results. Here you see the implant during placement. And we have to discuss what we will do in the lecture a lot, I think. What should we place in the gap there? And I will place something in there. Maybe jumping distance is nice, but I'm more relaxed when I have some difficult resorbable material in there, some xenograft, for example. So here the implant is in position, and we need to be 3 millimeters below circular outline, as I told you before. And then we can say we have a big chance to get a very nice result in a stable situation. As I told you before, I love to have a platform switch design there when I have a lot of soft tissue, at least 3-4 millimeters around my implants in every direction. And it gives me space to play with the tissue and to stabilize it at the circular outline. And here you see the final outcome in this situation. Of course, the attachment of the neighboring teeth is helping me It's a case where this was intact. We still have maybe some resorption, but we have a very nice result for 12 years now and a stable situation. And we have a happy patient with a very high laugh line and not accepting any aesthetic negative points in the treatment. So I'm happy that we could help her and that we were successfully treating her. Because it's nice to have great pictures in the first 1, 2, 3 months, but it's even nicer to have healthy situations after 10 years or longer. Immediate implant, always, to me, except when we have positive pain when we are tapping on the teeth, when we have soft tissue deficits, then I would be very careful. I would rather go to a delayed placement to correct it later on, with the second stage surgery, when we have inflammations or when we're not secure with the situation. When there's anything I'm wondering about, then I would go to the delayed approach, because then I have everything healed. I have a closed soft tissue. I can have a primary closure of the wound. I can correct later on with the second stage surgery, and this gives me a lot of confidence to be able to get to a nice result. So going through the timing to the protocol of immediate implants, it's all about the timing. Teeth with one root or no acute infection, to me, I would love to place it immediately. Teeth with more roots, maybe sometimes with more than 2 roots. You can do that. I did it before. I think maybe it's easier to do a delayed approach, but this is very personal and you have to decide yourself what you are doing with the more rooted teeth, if you also go to that concept or not. It is interesting, but to me then maybe a delayed approach more safe, and as less stress as you have, I think it's better for us and for success. Teeth with one root, okay, no acute infection, no pain with the percussion or with tapping on it. I would go for immediate implant, especially if I don't have a soft tissue deficit or some inflammations there. What you see here on the right side, if it looks like that, I would not go to a immediate implant placement because I would be afraid of the inflammation going on there. I would rather correct it due to the second stage approach. Gentle extraction, of course, it's a key factor for success there. I don't want to raise a flap. I don't want to do repairing techniques down there. I want to add material, bad resorbable ones or slowly resorbable or non-resorbable ones, to compensate the bundle bone resorption or the buccal bone plate resorption, which works pretty nice, I think. But I think it makes sense to take it out very gentle. And here you see a Benex extraction machine, which helps us doing that. Of course, we need some extra bone apically of our socket, of our tooth socket, to get some stability down there. And this is where we get it from. We are away from the buccal bone plate, so it's on the palatal side and it's on the apical area to get stability and safetiness for the treatment. And of course, we then have the big benefit of preserving volume, preserving tissue, not having a flap raised, not having resorptions there. I think this is a major and good advantage. So how far can we push the borders? And this is one of the cases I did in the past, and I'm not afraid to do it again, but I don't do that on a daily basis. And but I have to tell you, the cases I did that, placing an implant immediately in between the bone envelope, what you see here, I think it will work predictably. And maybe we need some growth factors, some PRF, sticky bone. I like to work with some autogenous bone on the surface of the implant, of course, and then over augment and use the correct membrane on top. I think we can have some nice success. What's irritating me is that we have some inflammations there, tooth 2-1 or number 9. When I still count correctly, intentional wise. This is what I don't like to see, and you either, I guess, and which I don't like to use as a situation for an immediate placed implant. But what I like is that I have some extra volume. So the tooth is shorter than the other one. So maybe we could go there. And then I looked at the, the tooth, and it's destroyed pretty much. I raised the flap and I took it out, and I got rid of all the granulation tissue. And still I said, okay, maybe the patient was so afraid from all the treatments and had so much stress. And I said, okay, let's push the borders. Let's take a look into that case, how far we can go. And I place it correctly, I think, on the palatal aspect of the socket. And I placed it stable enough. And I used some autologous bone to cover the surface of the implant. On the right side, you see what I showed you last time, the photo functionalization machine, the plasma sterilization, to get a optimized surface, biological activated, and getting more BIC on my implant. Very nice, published studies from the UCLA, Professor Ogawa, and so on. But I have no time to go into that topic again today. Anyway, here you see the implants covered with autologous bone, which I always prefer. I think my implants, if the surface is free of bone, I would like to have autologous bone there. And then I over augment with xenograft, for example, mixed with PRF, or here in that case with some perioseal liquid. It's hyaluron acid, which gives also a sticky bone texture to the material and stability. And then here on the right side, you see some PRF membranes. And also, of course, I will cover that up with a slowly resorbable and very stable membrane like the O6 one I showed you the last time in basically all of my cases. Then you get back to the second stage surgery right away. You put on a healing cap to close the opening. You know, it's an immediate implant placement. Maybe in the future we will have more and more what we already have now, three-dimensional or root-shaped healing caps, or maybe tooth discs. We will look into that later on anyway. And then we have a closure, and we have a nice healing, and we have an impression which we were taking after maybe 4 months. You still see some xenograft in there in the soft tissue, which is no problem at all. And then you see a root-shaped abutment for a cemented crown on top. When you have a design like this, cementing is no problem at all. And you see an acceptable result, I think, due to the soft tissue situation. This is very, very interesting approach, doing that all together, augmentation, having a big defect, immediate implant placement, and so on. And you see a stable result on the X-ray on the right side, and after 5 years, by the way. And I have to say, this is something which can work, and we can also use an immediate implant procedure in those cases. I think in many, many situations when we can place the implant in between the bone envelopes. So this is just a situation out of my office, yeah, and out of my experience. This is no scientific evidence-based know-how. This is just what I see in my cases and what we did. So it's a lecture from the office to the practitioners out there, and we of course have to discuss that with the scientific guys and with the studies that are going on and are very important, of course. Flexibility. We need to be flexible. Every case can turn out to be different, and we have to change our protocol. For example, here, I did not place an immediate implant. I just tried to get better soft tissue, and I placed a free-gingival graft onto the socket. And I said, okay, I wait 8 to 10 weeks. I think here 10 weeks, and I come back to place implant. And what happened? I got a perfect bony structure underneath. So this was very nice, because here the bone wall buccally was also very nice, I guess. And this is perfect. I take out a tooth, I have a little bit of a soft tissue approach, and I get an ideal situation to place very safely in autologous bone my implant. Something which can work very nice and be very predictable. So don't forget, when something is not okay, when you're not 100% sure that it's a good choice to place an immediate implant, put some soft tissue on top of those sockets, and then come back after 8 to 12 weeks and place it easily. or maybe do a socket regeneration with autologous bone in there. Maybe not with artificial material or xenografts also whatsoever. When you do so, you have to wait a very long time. Well, it's depending on the working style you like to have. In my opinion, I would rather not do that. Yeah. Also, I see a lot of great cases in that techniques, but to my working style, it doesn't fit so much. But here, this is amazing. You get a better result from the soft tissue. You preserve your natural healing, your blood clots, and you will get a very nice result. Maybe you add some growth factors underneath. And this is why I'm not happy with some bony substitutes material as a socket preservation technique, because this is what happened here. And I didn't do that in this case, and it didn't turn out to be very successful, which should not mean that all the things I do are very successful. I have all the complications everybody has as well, and I think it's never benefit to be too self-confident working on patients, because the next disappointment will come for sure. So always deal respectfully with biology, and still, to me, a socket preservation approach with bone substitutes like this here. I think this was algae-poor. It's not my favorite approach. And the colleague here, it was, by the way, a maxillofacial surgeon. I wondered very much that he was choosing for that protocol. He came later on to me after 1 year, and I should place an implant. And then we did what I like to do. I took out the material, I placed the implant right away into the defect, augmented with autologous bone on top, over augmented then with xenograft, using a very nice membrane here on the right side with a structure on top, giving me safetiness for stability for the next 8-10 months. And using the O6, and then the patient was gone again. He was from pretty far away, and I just saw him for the surgery, and it worked out pretty good. And next lecture, if you follow me, I'll be happy to see you there. By the way, I cannot see you, but if you see me, then for the lecture number 3, I will show you the final result, because I got the pictures. I was just forgetting to put it into there. Now it's placed prosthetically wise 1 year later on, and I will show you the results. So anyway, go back to a situation here, front tooth. I wanted to do a socket preservation with a tooth disc, and did not work. See how it came out. Was a case with a lot of inflammations before, a lot of apical root resections and so on, and I was too over-motivated to do this tooth disc technique, which is very nice, but not in that case with inflammations. And now, 12 weeks later, I have to deal with a lot of defects, a lot of volume loss. And of course, I can put a lot of material in there. And again, I did my incision palatal orientated, split flap design, and I was prepared. I had autologous bone from the retromolar area. I used the implant as a tent pole to stabilize the augmentation, and I used the PRF to get sticky bone. So that was my approach here. And of course, the O6 membrane to have a long-term stability and a safetiness for my augmented material underneath to be protected from ingrowing soft tissue. So here's the implant. It's a Megagen implant, AnyRich, with a very nice screw thread design, getting me a lot of primary stability without compressing the bone. And then you used it as a little bit of a tent pole. And I love to use tent pole screws, as I showed you in the last lecture. And I love to use my implants also for a little bit of vertical augmentation. Thrilling, but working nicely if you have a good soft tissue approach and no tension on the flaps. So here, 3 millimeters below the later prosthetic device, I want to place my implant. I think that's correct, everything. And I have to be good with augmentation. So in this case, it's only autologous bone with growth factors. Maybe it makes sense to add some xenograft on top of it as a resorption protection. This is my personal experience. Here, the patient didn't want to have that, and of course, I respect it. And there's nothing better than autologous bone, and I covered up with a 2-layer technique, like Danny Buser showed us in very nice publications here, with this membrane I told you before. So here the closure, no tension, but also not the kind of tissue I would like to have. And now I'm happy that I did a delayed implant approach. I had to do anyway here, but I'm very happy. You see on the left side, by the way, the anchor sutures getting the tension, and then the small closer sutures. And now I have, I have the chance, and I need to do that, the compensation of soft tissue augmentation during the second stage surgery. And this is what I did. I did a G3 gingival graft from the tuberosity area and placed it in front of my healing cap, stabilized it, and then later on I did an impression 1 week later, and 2 weeks later the patient got his temporary crown I showed you in the last lecture. And here you see, I think I showed the case a little bit, or 1 or 2 pictures or slides, and here you see the final outcome. It's not brilliant, but it's acceptable. I have volume there, I have a little bit of recession, I have not a high laugh line, and it's a demanding case. It's a lot of defect, and still I solved it in 1 approach, placing the implant, doing the augmentation, and maybe a second approach, correcting the soft tissue as good as it gets. And I think it's acceptable, it's okay. The patient's very happy, it's healthy, and it's stable for the last months, and it's nice white aesthetics. And of course, I know it could be 1 millimeter, 1.5, maybe 2 better in one of the others area, but I think for where we came from, it's okay. It's my daily office. It's daily case. To go from there to here, I think it's not too bad. So patient's happy, I'm happy, and at least it looks like a tooth and with some tissue missing. But anyway. Yeah, we should not be too critical. At least we have some nice cases like here. Here it's better. It's almost no tissue missing, but it was also a more easy case. It was immediate implant. And I want to be 3 millimeters below the outline, as I told you. So the position of the implant, that's very, very important to me. And then of course, hand in hand, the prosthetics, the planning, and so on. And we have to do everything to get there. And then if we have cases which are not going to be perfect, I told it to the patient before that I'm not sure that I can restore it like it was when he was 18 and healthy and nothing happened. So we have to communicate this with the patient, and then I think everything's fine. And we have to accept that the tissue is scar tissue around our implants. It's a chance because we can play with it, but it's also maybe a problem because it's different. It's not as good as the tissue around your teeth. It's different vessels, different fibers, directions, different quality. But still, when we put there a lot of the materials, then we can be very successful, especially with immediate implants. This is our general approach doing immediate implants. We take them out, maybe with a Benex extraction machine to preserve all the bony structures. And then placing the implants, doing an Ostel measurement to be sure that the stability is good enough for a immediate healing cap restoration on top, or maybe to do a immediate restoration at all. Later on, I will show you one of the other cases where we did that. I think we have to go to that side with the new hardware pretty much, or we can do that now, but always very carefully, because I think it's nothing worse in a daily office than when you have some problems or a case with non-success. This is to be avoided, I think, more than to be with the most aggressive or sporty approaches. Then in the gap, we will add some slowly or non-resolvable xenograft to stabilize the blood clots, and we close everything up with a healing cap or tooth disc. And again, we try to get some extra volume, soft tissue with a tunnel technique, and we're adding some tissue there. And this gives us some extra safety nets for some good red aesthetics later on, and stability and also blood support and safetiness for our reconstruction. Yeah, this is how we go on with our prosthetic devices. It makes them very concave, and later on we put some pressure on the cases to end up with a nice and natural looking situation. In the past, I was happy in 2000 with the publications of Peter Randelzhofer to place big implants, no augmentation necessary, 6.0 and so on, stereos or here Camlock. But then we were talking about recessions because we were too close to the labial bony crestal situation. So today, of course, we're placing it palatal orientated. We're trying to use thinner diameters than 6.0 or 5.0 and better fill those gaps with a xenograft, for example, to stabilize the blood clots. And I think this is the best way to do that. And then we can compensate a lot of that resorption, which is shown and published by the Swedish group. And the Swedish group are going back all to those dog models as well, with some nicely bone level implants, but still very, very big implants for a dog model maybe. So we also have to keep that in mind, because then we're again close to the level aspect, and that also means resorption, as I told you before. Anyway, every case is different, and we have to decide from the one or to the other case, maybe also different. That's what I want to have, an outline here. I want to push it with my prosthetic devices. It goes through a little bit faster here because I talked about it the last time. And then also the HAPIC concept, we are polishing it, not high definition, but a little bit more rough to get some structure for attachment of the soft tissue to our ceramic zirconium abutments down there. And here's the final result. I think it's a very acceptable outcome for that situation, also due to some extra tissue added at the time of the implant placement. Yeah. Controlled picture after 4 years, and then after 6 years, very stable, nice bone peaks in between the implants, far away, placed 5 millimeters in between. So 3.8 millimeter diameter implants. I think that's a nice nice way to do that, getting away as much as possible of the two shoulders of the implants, keeping the bone peaks intact, so and augmenting the areas around that in the nice socket, which is ideal for augmentation techniques. So the wound closure is always one of the biggest points. Here we used the healing caps. If we don't want to do that, or if the stability is not good enough, maybe we use connective tissue, as I showed you in the case where I placed a delayed implant, or maybe we can do that in combination with the implant placement. Also very nice. Mr. Stimmelmeier, great surgeon, and a great group of guys down there. They had nice publications to do so. CombiGraft means you have some epithelium still on top of the middle part of that connective tissue to close the socket, or maybe today we just make it easy and we use some collagen matrix or some membrane or Volumax volume to add volume and having a closure, minimal invasive. I think it's very nice to look also in those techniques and publications. And maybe we are again using just a gingiva abutment and using some sutures around it and filling the gap with a xenograft. All those things can work very nice, and we need to have individual decisions to have a wound closure. Let's take a look into that case. It's a lateral disaster case, missing 2 teeth next to each other. Very, very problematic. Everything will fall down and break down, and we have to decide what we're doing. 2 implants, 1 implant, and we would prefer to place 1 implant here, or maybe we would do socket regeneration and place an implant later on, or still we would not place 2 implants. I think when it's so close to each other, missing a lateral or a front tooth in the lower area, we would place a Pontic instead of 2 implants. Or maybe we would do a closure with a pedicular flap and just roll it over. Very predictable. This will gain a lot of volume. Very nice technique. a little bit more invasive, and maybe for 2 Ts, even too invasive. You need a lot of material, but still, when it's very critical and we are missing 1 tooth, I think this is one of the approaches we should not forget. Let's take a look what we did here. We replaced 1 implant. We put the heating cap on top right away. And this was the outcome on the model and the Pontic next to it. And we were going down straight 1.5 millimeters to stabilize the tissue ahead. And then the technician is putting a ideal tooth on the plastic cast model. And he's also performing the ideal circulatory outline, which is gained by these structures here. And then we're just copying the other side. And we did not augment so much. We were more supporting the tissue. We were trying to avoid resorption. I think this is the best approach we can have. Maybe adding some extra tissue, we can discuss that, which we also did here, a bit of connective tissue. And then we have the same outline on the left side than we have on the right side. And we copy it. We make a splint with silicone material, and then we just use a pen and we are painting it on top of the model. This is what we always do with our emergence profiles, also with molars whatsoever. This is the way we work. We don't use soft tissue mask. We use the plaster material, and then we drill it into the models. That's how it looks. And then we use a round drill, and we go 1.5 millimeters straight down. This will protect or support the tissue to the front, also at the Pontic area. And then we just break this little sharp edge to have not a ridge lap design. And later on, we add some material, we put some pressure on the soft tissue to get to the outline we want to have later on. Here, that's what you see. And then we go back to the patient, and this is what you get. You need a little bit of a team and some experience together that you can proceed easy and fast enough. What I did here, this is when I placed it for the first time. My technician Uwe Gehringer in Munich prepared it perfectly. You see a little bit of white structure there, so some pressure, but not too much. Due to the experience we were building up together. And then after 1-2 meetings, I put up some extra, we're building up some extra pressure to shape the papillae, to get some more stability in there. And then we get a predictable result. Here you see still the long-term provisional. This was a referring case. I did not do the final prosthetics, but this can work. Yeah, lateral disaster case, like the English-speaking people are saying, it's the most difficult thing we have. You will lose all the tissues, and the other side is still intact. Very difficult to treat. We were supporting it, we were preserving it, and I think it's an acceptable outcome for a case like this. To me, the ideal approach. If we have healthy structures, maybe a little bit more soft tissue, what we had here, then immediate implant placement, 1 for 2 Ts, only in that situation, by the way, for lateral, maybe canine lateral too. And then we were building everything up with some extra tissue, with xenografts, and preserving that areas. So let's go to the disc to show you some maybe new or newer things. My first case, using a socket regeneration with a tooth disc. Why not using nature? Nature is hard to beat for maintaining that structures. And I had to take out the tooth due to a internal resorption. And you see that here on the left side. And was a front tooth accident. It's ankylosed. That's why it's shorter than the other one. And tapping was also with a different sound. So it's difficult to take out the tooth. And a lot of bone came with it. You see here, I tried to be very carefully, but still a lot of bone was coming with the root. And you see the resorption. So I think there was no doubt to take out that tooth. I used the Stefan Neumeier protocol using a 3 millimeter disc, which I was cutting out of the root with the fibers on top, the vital ones, the bleeding ones. I filled this opening from the root canal treatment or from the nerve canal here. It was not treated before. And then I placed this root disc to close the wound with some sutures. And then I came back after 10, 12 weeks, 12 weeks here. And I didn't used to have to do a flap. I took out the disc, which I was placing the other way around. So you see the buckle part is facing palatal wise. Maybe because it was my first time and I was too nervous. And then I placed the implant, and I was irritated because I did not have to augment anything because there was the bone down there. And it showed me that there is so much regeneration potential in that ligamentum circulare around our tooth discs. It's amazing. I did not have to use xenografts or whatsoever. It was strange to me, this experience. After 12 weeks, natural healing, only tooth disc and some blood clots underneath. And then I placed the implant easily and I put back the disc, and that's it. And then I did my registration during placement with the splint. I picked up the implant position. I placed it back on the study model, and the technician performed already a temporary, which I could easily place after the healing period. So here's the implant situation, and this is to me, this is socket preservation. See the bone labially, and I showed you the picture. The cortical bone was gone. It was on the ankylosed tooth, and I was totally amazed that this is possible. It showed me the potential of the tooth disc protocol. And here you see young bone. You see the wall still there or regenerated, and just this is, to me, this is socket preservation. Second stage surgery, I took out the disc. I placed the temporary 3 months later. That's it. I did not do anything. Maybe one time I built up some pressure to get some pressure on the soft tissue to get better papillae. And here you see the integration, unbelievable. All bone around the implant, all bone around the abutment. I have to be very slim that I don't fix the prosthetics on the bone. And to me, this is what I love to have. I want to have a lot of bone down there. I don't want to have resorption around the neck of my implant in the first place. 4 months later, patient want bleaching. So of course she could do that. She did, and it gave us some trouble with the color of the final crown, which we were already working on. But anyway, I think it looks nice, and to me, the soft tissue is fantastic. Knowing that I didn't do a lot. I took out the tooth, I placed the tooth disc, I placed the implant. I did not do any other augmentation techniques, and this shows me how much potential is in that tooth disc technique. So we said, okay, why don't we do that with immediate implant placement? And we did. Let's go fastly through this case. Again, I have too many slides for the 1 hour and 50 minutes. I try to be in time. Sorry for that, guys. So I go a little bit faster. 2-1 and 2-2-9 and number 10 have to go due to endodontic problems. So far, we had already before today, we took it out carefully. We preserved the bone, and we got the disc again, the one with the vital fibers on top, the red ones. Now here, this is after drilling, so they're looking white, but they're still vital, hopefully. And now we do the discs a little bit shaped like the alveolar ridge. So they're fitting better, and it's even more biological adapted. And then again, we place the implants here. We have the AnyRidge Megagen implant with the same prosthetic platform, which is pretty small, so we can be away from the threads and we get perfect stability, and not even with bigger implants, not being too much labial. So ideal for those situations. We are filling up the, the gap with a xenograft. And here we put the tooth disc on top just to closure everything, no suture, nothing. And we did some augmentation of the pontic area with some PRF. Maybe we have to discuss better here to place some xenografts to get some more stability in there, but you will see on the end, maybe it could have been better here with some xenograft. Here you see the tooth disc in place, implant underneath, and nice structures, at least at the day after the surgery. No swelling, no pain, almost at least, nothing. So very minimal invasive, very nice stability of the implant. Due to the thread design here, you can choose with a lot of amazing, bigger, smaller threads, very good stability. I didn't have a longer one, so normally I would have placed a longer one apically, also with Megagen. But due to the study we were doing here, I didn't have the right length, and back then I didn't have all the lengths. Now I have. So place it apically, absolutely. But if you don't have long enough implant, use one with a screw design like this. It will help, because this was stable like crazy. Anyway, here's the outcome. We were using an impression post, trying to have an long-term provisional, and we were thinking a lot how to take it out, how to deal with the tissue, knowing that everything will collapse immediately. And we tried to be very fast. The fabrication of our temporary slide I showed you before, I was not palatal enough to have a screw retained restoration, which I would prefer in that case. Of course, having a pontic on there. We could still think of bonding a veneer on top, but here we did a cemented restoration with a facing on tooth number 1-1. So a facing 1-1 or number 8-9 implant 10A pontic, and I think very acceptable result here due to the tooth disc protocol for immediate implant placements. Some critical parts, some parts where we could have been better, but I think, to be honest, it was already limited here in between, and I'm very happy with the outcome. Patient happy, very stable, very predictable, very minimal invasive. Something we have to talk about, something which is maybe very interesting. 2016, we had 22 cases. We had no major complications. We lost 2 times a disc, but it didn't affect the further treatment. We just went on like we used to do with a delayed implant placement. So there was no bigger problem. Today we have 85 cases we're looking into with the group of Marco Schlee and other very famous dentists here and good doctors, and Stefan Neumeier, of course. And I think this is something he published first, and I think very interesting to play with nature, to play with attachment, to get better results. So here, a little movie. We still have time to show it. With that screw design, very nicely solved, I think, very minimal invasive. That's a movie. I go ahead a little bit. Number 9 has to go. Here's the socket. I took it out very carefully. Then the drilling, as I showed you in the literature before. Palatal orientated. Then the final drills, just the same protocol you used to have, or you know, of course, to place the implant, thicker one. It's always the same prosthetic platform, so you always far away enough from the level aspect. Here you see situation. Here you see the plasma activating device. We take out the implant. It's activated. It's hydrophile now, optimized for better bone implant contact. We are stabilizing the implant, that it's not getting its way to the level aspect, that it's staying palatal, because it would love to go there, because there's no it's not stopping there. It's no contact with any hard structures. Now the implant is placed, I think, correctly. We're trying to get a nice stability of about 35, 50 Newton centimeters. And we're filling up the gap. We are checking, of course, the Newton centimeters. And then we're doing the impression fixation, or the registration. This is a little template. Here. This is a very nice material. It's light curing. And then we're adding some more liquid composite, and we are bonding it together with light curing technique again. And then we take out everything, and it goes to the laboratory, and the dental technician can perform a long-term provisional for the time when the implant is stable and healed. Yeah, and we're also using that for placing the next day a immediate restoration in the situations we can do that. Now we take everything out. And then it goes to the lab technician. So it goes. Then we were getting the disc using the fibers, the one which are still vital, which have having blood on it. And then we're taking out a little disc with some discs as well. Underwater cooling, very important. It's about 3 millimeters. And then we're placing it on top. Underneath, it's the implant, it's some xenograft for stabilization, the blood clots. And then it's here, it's some little bit of PRF also underneath, which we don't always use here. And then we have the disc on top. We shorten it a little bit more, replacing it, and it's still shortened in the mouth of the patient. And this is how the patient goes home. PRF underneath, and then we are placing the prepared disc on top, holding it for some time. And basically, you don't need some extra sutures. We are just using the disc, and when the pressure is not enough, when it's not fitting enough because you have to use the lower part of the root, then we use some additional sutures to have a nice fixation. So this is the outcome. No. Oops. Here's the disc again. I hope it became clear how we do that. And then we take out the disc after 3 months and we're placing the long-term provisional, and later on the final crown. This is what you see here with a very minimal invasive approach. Very easy, very nice, and very predictable. So immediate implant placement today, I think, means that we can use different techniques, discs, delayed, or using the gingiva shapers on top. And I think we have more possibilities, and we can also, when we have defects of the lateral aspect, what you see here, we can also perform some regeneration. And then you can use some nice membranes like the Ossix, which is stable for a very long time, that you push that around the borders of the defects and still add some extra bone material, osseous bone on the surface, and then maybe xenograft on top to cover up everything. And then you can end up with some collagen graft on top, or some Volumax, for example. And you can place an implant next to an implant, easily minimal invasive here. And this is after 10 days and open healing. And then you get still some very nice emergence profile, very easy, very minimal invasive. And still you can add your techniques with a lot of augmentation. And I think this is something we have to keep in mind. It's, I think we can push the limit more and more into the right direction when we, or the more aggressive direction when we respect the biology. Let's check the time. I know I'm 3 minutes above my speaking time. Maybe I can show the last case. I would love to share that with you. Let's do it very fast. I hope that's okay with you guys. Paul?
It's okay.
5 more minutes? Okay, thank you.
Yeah.
So it's
Go ahead.
because this is what I wanted to show you. It's one of my latest cases, and I'm very happy with it. It's a 1-2 which is persisting, and a Agency at a 2-2. It's a limited bone volume, and I try to do great planning, and I have this new hardware, Megagen implants, and my regeneration procedures, and I wanted to do immediate implantation plus immediate restoration. So we were always very very restrictive with immediate restorations, but now with the new hardware and with the knowledge we have now that the primary stability with that screw design doesn't drop down in the beginning, we are more we are maybe more aggressive and doing it more often. So here I promised it because the soft tissue looked great. What you see here is a lot of tissue around the bone. So I thought there must be some bone underneath, but it wasn't. I did a 3D planning. So I was prepared, but I didn't look into it. And I did that case for a lecture here in Munich half a year ago. And then I did my planning one day before the surgery, and I said, oh my God, this is not possible. It's 3.3 millimeters there, and it's not lying here, this 3D scan. and it's 2.5 millimeters on the other side. So I said, how could I place the implant there? And I did. I had to anyway, and I wanted to restore it right away as well. And let's take a look. I said, okay, when I cannot place it, then of course I will do only augmentation procedure. I go a step back and we do everything later on, of course, but it worked, and I want to share it with you, and I would love to discuss it with you later on, because showing you this doesn't mean that you have to do that all the time. Tooth one tooth still there, the other one is a adhesive bridge. And of course I started with 1-2 because the bone was a little better there. I did an approach, a flap, small one with a little bit of a vertical incision distally. Had my drilling guide, and at least at the crestal area I had some bone. And the Megagen implant, you need to know, the 3.5 millimeter has a core from 2.8 millimeters. So it's very slim there and still has some threads for stability. So maybe this design is very fitting for limited bone volumes. So I could easily place the implant, and I could do some bone regeneration, and I did some osteal measurements. It's 80, so that's a lot. That's good enough for a early restoration procedure. Again, I did my registration here, as I showed you before, and I put some autologous bone on the surface, some xenograft, some ossix membrane for a good regeneration there. And then I took my gingiva cap on top and closed everything. So now the other side. This turned out to be good. I tried to put some extra volume there, and then to follow, and then it didn't look so good. So I used a very carefully drilling protocol, and I used some osteotomes to get some extra bone there. And again, I placed my implant. It was possible, 3.5 millimeters, and I did some augmentation, and again, my registration. Here you see the augmentation of autologous bone again on top. So everything was fine. Also due to the hardware, of course, it was perfectly fitting here, that screw design. And I closed everything, and I tried to put some extra materials there because I knew I'm missing something here. The next day, it looked like that, and I tried to place my temporaries or my prototype crowns. Dental technician did this, prepared it. Here you see slides where we put it with a lab analog underneath on the situation models and the digital planning. And here 2-2 has to be shorter. We want to be on one line, want to respect the aesthetics. We have always screw retained provisionals in all those cases, no matter if we are touching the labial part. Later on, we can change that or do some cemented crowns, but not in the temporary phase. Here you see it on the model, and then placed in the mouth of the patient. So, and now we have a lot of tissue, we have a lot of volume, we keep in place by the prototype crowns. We have it on one line now. We put some pressure on the 1-2 situation, and we adding some material on the 2-2 situation. And this is how it turned out 1 week later. And then after a few months here, healthy situation, supported by the temporaries. Still, we have to work on the papilla here. I see that, of course. We have to be better, but it's also dominated by the attachment. Cleaning was not so good here as well. But anyway, we are doing that with a total digital approach and with an analog approach. And still here, the temporaries. But what I want to show you is that we have here a very fast, very minimal invasive approach to protect tissues. And I think we can push the border a little bit more to immediate implantation, immediate restoration when the cases are fitting. Yeah? And the conclusion is you have to find your right way. You have to stick to the techniques which are using in your working in your hands. Don't change too much at all, but also be open for new things. And I think there's still a lot out there to come, and we have to get our practical know-how back into our cases to be successful. But don't forget, immediate implants can be very nice. Bone regeneration can be also okay. I'm more fan of delayed then, early and delayed. Don't forget the tooth discs. And then I think we were seeing, hopefully, at least some interesting things tonight. And I'm looking forward to the discussion right now. It's digital, and hopefully that's what I'm ending always. Still a lot of analog things to do. And thank you very much for your time and your attention. So sorry for being a little bit too long here with my lecture.
It's okay, thank you. Just a second. All right, just a second. All right. Yeah, so thank you so very much, Dr. Randelzhofer. Before we will answer the questions the audience raised along the lecture, I would like to inform everybody of our next webinars. As mentioned this at the beginning of today's session, this is the second session out of 4. The next session will be of the series will be on May 4th and then on June the 2nd. On March 24th, Dr. Barclay will discuss about the vertical augmentation, challenges, and alternative techniques to achieve uncompromising clinical solutions. And on March 31st, both Dr. Matthew Fine and Dr. John Kim will be having a clinical discussion about improving hard and soft tissues, hard and soft tissue contours around the dental implants. On April the 7th, Dr. Tara Agalo will discuss about common complications in GBL augmentation. And to review the entire list of events, you're all more than welcome to enter the Datum Dental's website. Lastly, before we will go to the Q&A, I would like to ask everybody here to fill out the webinar survey, which can be accessed either by scanning the QR code on screen or using the link in the chat pane. Please dedicate only 3 minutes to fill it out for our future improvements. Your opinion is highly important to us, and we really appreciate it. So as promised, let's go over the questions asked by the audience, right? And we will now go to the questions, just a second. And the questions are on screen for you, Dr. Randelzhofer. Here's the first one.
How do you determine implant size in immediate implant, since we may have bone lost afterwards? Okay, my goal is not to have bone loss when I do an implant, an immediate implant, by the way, but to try to give you the correct answer, I choose the size of my implants to stay away from all the critical areas. That means I try to stay away from the level aspect, 2, maybe 3 millimeters. I try to be away from attachment of the neighboring teeth, at least 2 to 3 millimeters as well. And I try to stay away from one implant to the other, if possible 5 millimeters, or 3 to 5, when I can 5. So I rather use thinner implants than a thicker one. And yeah, that's how I would deal with it. It's also depending, of course, on the screw thread design, how much stability your system, the one you're using, is giving you. But I think the correct answer is that I would try to stay away from these critical areas as much as I can.
All right, thank you. Next question.
Depends a little bit on the biotype of the patient. When I have a thick biotype and a lot of tissue and a thicker labial bone plate, which I can, of course, detect when I take out the tooth, I would not add a extra soft tissue. When I have a thinner biotype or a very thin buccal bone plate, I would add a extra tissue material, and I would add, for example, Novomatrix or Volumax, for example, which is very nice also to get bone and soft tissue. I think very interesting material, or a connective tissue graft to the labial aspect. And I would do a tunnel technique coming today from a lateral approach with a lateral incision. The one you saw in my lecture was throughout the sulculary outline. I would rather leave that area more intact and come from a lateral vertical incision. I will show you some cases in the next lecture and in part 3 and 4, where we have some cases which we were doing over, and we have to do everything new, or where we have to deal with some more severe defects. So
Right, thank you.
I think it's answered correctly.
All right, thanks. Next question.
Do you perform a dual bone augmentation as Dennis Tano suggests with immediate implant placement? I have to say that I of course know Dennis Tano, and I know his ice cone technique and so on, but I don't know what he's calling or naming a dual bone augmentation. I hope I showed you precisely what I do with my cases. So what I do is I place the implant and I fill the gap with a xenograft, porcine material in my cases. It's from Regident, you can get here over here. And this is what I like to use to stabilize the blood clots. And when I have a defect of the buccal bone plate and I do the more advanced immediate implant placement, I use autologous bone always on the surface of my implant, place it in the bone envelope, and then I over augment with a xenograft, always mixed with PRF. And then with a normal immediate implant placement, when everything is intact, I don't use a membrane. When I have a defect, I would use a 6 membrane, for example.
All right, thank you. Next question.
Okay, I'm more happy when I can fill the jumping gap, because then I don't have to rely on the jumping of the cells, and I have something stable in there to stabilize the blood clots. And I use PRF and xenograft as a mixture, preferably with porcine origin. And why? Because it's more stable and not so I don't have to deal so much with resorption then.
All right, thank you. Next question.
That's a very good question. So I see the person who was giving it to me was watching the end of my lecture. It's going about the tooth disc. The tooth disc is a tool to stabilize the whole biology of a socket, and it helps regeneration. And we're using it for socket preservation techniques, taking out the tooth and just placing it for regeneration, and then we are waiting about 10 to 12 weeks. When I say 10 to 12, it's always better to wait 12. Maybe I hope 10, but to be on the safe side, it's always better to wait a little bit longer. So I wait 12 weeks. And then I come back and take out the disc, place the implant, and put back on top, put the disc back as a natural healing cap again. When I do an immediate implant placement, I again use the disc, if it's fitting, for closing everything up as a natural closure again with the attachment, the one I try to show you in the lecture. And then I wait as long as the implant needs to be stable. I wait for 3 months, 4 months, and due to PRF and photofunctionalization of the surface of the implants, new thread designs, it's getting the waiting time shorter and shorter. So when in the past I used 4 months for little augmentation cases, I would wait only 3 months anymore.
Thank you. Next question.
In most front tooth replacements, you always placed a crown on the natural tooth next to the implant crown. Is that true? No, I would never do that. So when you watch the next lecture, I will show you a lot of cases where we don't use the crowns to the neighboring teeth. So when I remember correctly, I think it's not true that I used neighboring crowns. I think you have to Is it possible to watch the video again for the practitioners?
Usually when people register to your sessions, afterwards they receive about a week after they receive the recording of it.
Okay, so
if you register, they will receive the link. Yeah.
So please take a close look again. When it's 2 crowns, it was two implants next to each other. In the one case, the one crown was root canal treated. I placed one next to it, but I think in 70% or 80% of the cases, there was no crown next to the implant. And if you take a close look to the prosthetic, prosthetics, which was shown, it's so brilliant, and it's not my credit, it's of the dental technicians over here. They don't need the neighboring crown to get a acceptable aesthetic result. So please take a look. I will take a look into it as well when we're finished.
All right. Next question.
On the tooth disc technique, do you grab the socket below the disc? This bone graft substitute before placing the tooth disc when you go back. Okay. No. When I use the disc for a socket preservation technique, then to place the implant delayed or after 12 weeks, then I don't put anything into the socket. I don't like to put things into a socket. Maybe PRF or blood gloss. I think that's perfect, and that's what I did in that one case. And the disc gives you so much biology and so much potential of regeneration. You don't need material in there. I think it's more disturbing, the regeneration, especially in the first 12 weeks. When you do socket preservation with bone material, I think the best material you can use is autologous bone and not a xenograft. When you use xenografts, for example, you have to wait for a very long time. You still can do that, but I think to be safe, you have to wait. I know brilliant publications from colleagues like Dietmar Weng, for example, but he's waiting eight months or longer. And when you go in more early, it's still soft. And to me, it's not so, but it's more my working style. It's not that I say it's not correct if you do that, but it's not my favorite approach.
Thank you. Next question.
A plasma activation device is a sterilization and an activation of the implant surface before you place it. There is a very nice publication of Professor Ogawa, who was using UV devices to activate the surface and to get a better bone implant contact rate. With normal implants, you have a procedure going on in the packaging that carboxide molecules are sitting on the surface of the implant, and you have not all the spaces of the titanium free for bone cells to lock in. So when you clean the molecules and to get a fresh surface, a hydrophile one, electrostatic optimized, then you get the attention of all the bone cells, and you will have about 97% bone around your implants. So this gives you more stability, more safetiness, and I think a very good biological approach. And if you're interested in those techniques, then you should look up Professor Ogawa's publications at the UCLA, very nicely, Department of Professor Moy.
All right, thank you. Next question.
Yes. When you have a root disc, which is when you have a tooth disc which is perforated or with an opening, of course you have to fill it with etch technique and with composite to be able to protect bacteria walking in and out, of course. Yeah.
Thank you.
Yes, you can, of course. When you look at it's more difficult to get it out in one piece and to keep everything stable. But when you look up Stefan Neumeyer's publications, He's using tooth discs in periodontal disease situations, where he's using little distraction devices after 2 weeks of placing the disc, where he is putting pressure on the disc, and he is distracting or doing an extraction of the disc, and he's getting a bone there. So it's a very interesting tool also for molars. So maybe it's interesting for you to look up Stefan Neumeyer's publications.
Right. That was the last question, Dr. Randelzhofer. With that, I would like to thank you so very much for your time, efforts, and professional input. And thank everybody for joining us today. And I hope to see you all in our next events. Thank you again, Dr. Randelzhofer.
Yes,
thanks for everything.
Thank you, and thank you for watching, of course. Okay, right. Bye-bye. Have a good evening or good day.
Thank you, everybody.
Thank you.
Thanks.